Gulani, a second-year medical school student at AKU and the manager of outreach at the Neuroscience Interest Group. We are honored to have Dr. Juma as a chair of the session and Dr. Kiran Hilal as a co-chair of this session. Dr. Juma completed his MBBS in 1976 from Dow Medical College, followed by FCRS from Royal College of Neurosurgery, England. His training includes residency in general surgery, neurosurgery, and fellowship in epilepsy surgery. He is one of the senior most neurosurgeons of Pakistan. While at JPMC, he played a key role in further establishing the neurosurgery center that was initiated by Professor O.V. Juma, the pioneer neurosurgeon of Pakistan, and his father. Professor Juma was also the first neurosurgeon to start neurosurgery services in AKO. He was also the director of JPMC and then director of General Science of Health. His research focuses on global health aspects of neurosurgery, particularly traumatic brain injury. Dr. Kiran Hilal is an instructor in the Department of Surgery and head of the Division of Artificial Intelligence at the Office of Academia. Okay. Can you?
Oncology. So here I am. There was a little bit typo error. So I work here. It's okay. You owe me for that. You owe me for that.
I would like to mention one thing that the participants have 2 minutes, right? Is it? 2 minutes.
So each of the presentation will be 20-minute long, and when 2 minutes are left, like 18 minutes are up, we will signal. The backend moderator will be sitting here and they will signal when 2 minutes are left to the end of the presentation. Thank you.
Thank you. I would like to hand the floor to the Dr. Kiran Hilal. Thank you.
Right, good morning. And on behalf of my co-chair, I'd like to welcome all the speakers to this session. And what we are going to do is to go through the presentations. And at the end of it, we are going to pose questions to the speakers. So if you do have questions relating to any one of the talks, I urge you to please write them down and pass them on in the chat box. And then we'll try and pose them when the time comes. So can I invite Dr. Kiran to invite this first speaker?
So the first speaker of the session is Dr. Sara G.M. Piccirillo. In her introduction, Dr. Sara G.M. Piccirillo is an assistant professor in the Department of Cell Biology and Physiology at the University of New Mexico Health Sciences Center, and she's a full member of UNM Comprehensive Cancer Center. And she, for the coming 20 minutes, she'll be talking about the dissecting the genetic phenotypic heterogeneity of glioblastoma residual disease. Dr. Sara, stage is yours.
Okay. Thank you for the introduction. Can you hear me and can you see my screen?
Absolutely, we can hear you and we can see you. You look beautiful.
Perfect. All right. Well, first of all, I wish to thank all the organizers for inviting me. I'm also really impressed by the quality of all the presentation, and I'm delighted to be here and joining you from the University of New Mexico Health Science Center. So what I'm going to do in the next 20 minutes is to give you an overview of our research that focuses on human glioblastoma. And in particular, we are interested in dissecting the heterogeneity of this very aggressive brain tumor. So as you all probably know, glioblastoma is a very heterogeneous tumor. The standard of care consists of debulking surgery where possible, and that is followed by radiotherapy and alkylating therapy based on temozolomide. And then there is a maintenance therapy based on temozolomide. But unfortunately, even with this current standard of care, the survival for glioblastoma patient remains very poor. And in fact, in this table, as you can see, when radiotherapy and temozolomide are combined, unfortunately, the median overall survival is still below 15 months, and the median progression-free survival is actually less than 7 months. One of the most important features of glioblastoma is that it's extremely treatment resistant, but also is really extensively heterogeneous. And when we say heterogeneous, we mean that it has a biological complexity that can be seen both at genetic level, but as well at the level of the cells. And so our contribution to the field of glioblastoma has been in addressing the spatial genetic intratumor heterogeneity. So as you can see in this schematic, what many people were doing was just to get a single sample from a glioblastoma patient, and they were profiling this single sample. And based on that single sample, there was the assumption that that single sample was really representative of all the complexity, biological complexity and the genetic of that tumor. Instead, what we did was to collect multiple sampling from the same glioblastoma, and we were profiling each of these samples separately. And when we did that, we observed an heterogeneity when it came to the genetic alteration, as well as the cell feature. For example, there were cells present in one of the areas that were more treatment resistant than cells present in the other area. After us, this type of approach has been extended also at single cell level, and other groups have shown as well heterogeneity by simply profiling and doing sequencing at the single cell level. So the way we did all these, and we tried to understand the extent of spatial genetic intratumor heterogeneity, was based on a method that is very well known in the clinic, and it is the 5-aminolevulinic acid method, and that's abbreviated as 5-ALA. So 5-ALA administration is given to patient prior to surgery to allow a better resection of the tumor. And you may probably know that 5-ALA is a precursor of the M biosynthesis pathway. And so as you can see in this schematic, what happened is that through a number of steps, 5-ALA is converted in the cells into protoporphyrin 9. And protoporphyrin 9 has fluorescing properties. So when the patient receives 5-ALA before surgery, what happens is that then the tumor cells accumulate protoporphyrin 9. And this accumulation can be visualized because, as I mentioned, protoporphyrin 9 has fluorescing properties. And so in the OR, if you have a microscope with blue light, you can now see that the tumor becomes fluorescent. And these allow a better resection of the tumor mass and really guide the neurosurgeon to perform a better resection. So we thought of using this method in our research. And we have this possibility of using fluorescence as a method to now understand spatially how we can detect and we can sample different areas of the same tumor. And so in an initial approach that we presented and we published in 2012, we were able to get from each glioblastoma the tumor mass that, as you may expect, of course, is fluorescent, the necrotic material that, as you know, glioblastoma is highly necrotic as well, and that is not fluorescent because it's mainly composed by dead cells. And then, more importantly, we were able to then sample the margin. And the margin represents the interface with the normal brain, therefore is 5-ALA negative, so is not fluorescent. In order to validate that we could use 5-ALA to sample different areas and now to dissect genetic intratumor heterogeneity, we had to perform histological analysis. And by histological analysis, we could see that indeed the tumor cells area was characterized by high proliferation and small area of necrosis. The necrotic material that here is abbreviated as N was mainly composed 90% of dead material as expected. And more importantly, the margin was actually histologically looking really like a normal tissue. And only 10% of the total cells in that area were tumor cells. And so by using 5LA, we had the opportunity to now look specifically at the margin area of glioblastoma and to perform, as I mentioned, this spatial analysis. And so throughout the years after that approach, that publication in 2012, we published other paper by also refining this method, and we call it the fluorescence guided multiple sampling scheme. And so all this work is published and allowed us really to interrogate glioblastoma at spatial level by looking again at the margin, at the necrotic, and multiple samples from the tumor mass. We were also happy to see that many other investigators around the world employed the 5LA for research purposes. And so these are only some of all the publications used by others in which they employed our FGMS scheme. And they use that essentially to understand the glioblastoma evolution and also to better characterize the glioblastoma cells phenotype. But for us, really, why this method that, like I mentioned, we call the fluorescence-guided multiple sampling, so abbreviated as FGMS, is so powerful, is because for the first time, it allowed us to objectively identify areas that usually are left behind during surgery. And as I mentioned up to now, I've talked to you about the margin that is also presented here in this little schematic. And the margin is, of course, non-fluorescent and is an area of residual disease. But we, by using FGMS, were able also to identify another area of residual disease that is abbreviated here as SVZ. And SVZ stands for subventricular zone that, as you probably know, is the most well-characterized neurogenic area in the mammalian brain. And so by using 5LA, we were able to see that in the 65% of the glioblastoma patient, there was fluorescence also coming up from the SVZ. And so that suggested that there were tumor cells in the SVZ. What we did then was to perform a genomic analysis. And again, all this is published work if you're interested to get more details. And we were able to position the SVZ in phylogenomic approaches. So we were trying to understand how each of these glioblastoma developed in each of the patients. And also to understand what was the role of the subventricular zone and the margin. And in order to do that, we used the bioinformatic tool that allowed to reconstruct the tumor evolution. More recently, by doing a longitudinal analysis of matched primary and recurrent tumor, we were able to look at the role of the SVZ and the margin at the level of the primary and that of the recurrence. And we were able to show that both of these two areas of residual disease contribute to seed the recurrent tumor. So it's really important to study not only the margin, but also the SVZ, because this area is important for when the tumor comes back. So all this published work that I was referring to really highlighted the heterogeneity of each glioblastoma and the importance of this residual disease area, and the fact that FGMS can be used as an objective method to identify and characterize tumor cells in this area. However, up to that point of our published work, we were only focusing on the tumor cells. And we were isolating the tumor cells from, of course, the tumor mass that is 5LA positive, subventricular zone that also is positive, and the margin that is negative. But more recently, we have been focusing on analyzing the entire tumor microenvironment. So both the tumor cells and the non-tumor cells that are present in each of these areas. And so now, for the rest of this talk, I'm going to show you the data for this approach, and all of them are still unpublished. So the first thing to note is that we can employ FGMS also to study the tumor microenvironment in the margin and the subventricular zone. And definitely is always the same approach. We collect the sample and we dissociate to single cells, But at that point, the main difference is that now we don't want only to enrich and focus on the tumor cells, but we want to preserve the entire cellular composition in the margin and the subventricular zone. And so we need to be very careful in doing this dissociation to single cells. In order then to characterize the composition of the cells in each of these areas, we perform single cell, single nucleus RNA-seq, and also functional phenotyping analysis, which is a cutting-edge method to understand the role of each of these cells in the SBZ and the margin. And so just to highlight that our approach really goes straight from the operating room to our laboratory and consists of getting each sample from glioblastoma and then perform tissue dissociation and trying, as I mentioned earlier, to preserve the cellular composition in each of the area. And in order to do that, we avoid enzymatic digestion of the sample. We don't do cell sorting. We don't do in vitro passaging because we don't want to alter in any way the cellular composition. We don't want to lose the most fragile cells. And also we don't want to alter the cell surface marker expression on these cells. We optimized this protocol and we repeated it on all our collected glioblastoma multiple areas from each of them. So here, as you can see, this is a table summarizing all the glioblastoma we have collected so far. They are all IDH wild type, and they are 30. And we collected multiple samples from the tumor mass. But more importantly, we collected also the tumor margin. And in particular, so far, we collected 34 samples of the tumor margin. And so we also collected the SBZ, as you may imagine, but for the rest of this presentation, I'm just going to present the data on the tumor margin. So the first thing that we noticed by doing a single cell RNA-seq is that we wanted a confirmation at single cell level that the cells in the tumor margin were, a majority of them were non-tumor cells, and only approximately, like in our previous study in 2012, 10% were tumor cells. And so we did an approach in which we can infer about the genetic alteration based on transcriptomic data that we generated. So what you see here is a UMAP plot for this case, GBM1, and this is the margin sample. Each of these dots is a single cell. And when we do this inference approach to understand the presence of genetic alteration in each of these cells, what we found is that, as you can see in blue, the majority of the cells in this area are non-tumor cells. And that was reassuring for us because it means that we were sampling correctly an area that is the interface with the normal brain. And as you can see in red, only a minority are tumor cells. We then performed the cell type annotation for each of all the analyzed margin. And what we found very consistently is that the majority of the non-tumor cells in the tumor margin are macrophages. And so that is really suggesting that there is a crosstalk between the minority of tumor cells in the margin and these non-tumor cells that are macrophages that are very abundant in this area. We then performed an analysis by looking at more than 400 markers of the myeloid lineage because we were intrigued by this finding that the majority of non-tumor cells were macrophages. But we couldn't find any consistent expression of this marker. We also looked more specifically at microglia because by cell annotation tool, they are also classified as macrophages. But again, we couldn't find anything that was striking in terms of marker associated to microglia in our margin sample. We then went more specifically and looked at a subclass of macrophages, particularly the monocytes-derived macrophages. And again, while the there are a few markers that show expression in the margin, we couldn't find a specific trend. We looked then specifically at the M1 and M2 polarization of macrophages, and you may be familiar with that. That suggested two phenotypes of macrophages. One is tumor suppressive and the other one is tumor supportive. But again, we couldn't find anything specifically. We also repeated all these analyses on the matched tumor mass from each of these glioblastoma. And so we were also, interested, of course, in looking at the composition of tumor versus non-tumor cells in the tumor mass. And again, as you can see here, we have an opposite situation as in the margin, in the sense that the majority of cells in the tumor mass as expected are tumors, and only a minority are non-tumor. And again, we performed cell type annotation. We looked at trying to dissect all the cell composition in the tumor mass too. And we found that again, those non-tumor cells are macrophages. We repeated the same analysis, and I don't have time to go through all the data, but again, we struggled really to understand the cell type identity of these macrophages. We took a different approach then to look more functionally, and we employed a computational tool that has been published. It's called the Max Spectrum. And Max Spectrum, what it does, it assigns to each of the cells that you want to investigate a functional status. So we were looking at maturation and polarization states of these macrophages in the tumor margin. And here I'm showing on the right 4 patients, GBM3, GBM16, GBM10, and GBM20. And what you can see in this graph in green is the macrophage population from the infiltrative margin. And in red are the macrophage population from the corresponding tumor mass. And what was striking for us to observe is the fact that we could see that the green, the macrophages in the tumor margin, were actually occupying all the different quadrants of this output that is of Max Spectrum. And so if you can look at what is shown on the diagram on the left, you can better understand what this means.
Dr. Sara, you have 2 minutes.
Yeah, perfect. Thank you. I'm about to finish. So what you see here is that the Max Spectrum allows to assign an M1 or M2 states to these macrophages. And so it seems like the macrophages in the tumor mass were more like M2-like. Instead, the macrophages in the infiltrative margin were both a composition of M2 and M1, suggesting a huge heterogeneity at functional level of the macrophages in the margin. We then went on and performed pathway analysis, and we were looking specifically at pathways that have been associated with M1 and M2. We could see again that some macrophages express specific pathways, such as antigen processing and presentation, and some other instead were associated with pathway related to oxidative phosphorylation. And to confirm this, we then performed a cluster-to-cluster enrichment analysis in which we were looking at the specific biological processes between these 2 types of macrophages. And all this is again back to the GBM1, the first case we got, and the tumor margin in that sample. So in summary, what I've shown you is that we believe strongly that FGMS can be used in research, not only in the clinic, because it's an objective method to identify different areas of glioblastoma. And we have optimized a protocol to now preserve the cellular composition of the tumor microenvironment in each area. And in particular, we are interested in the infiltrative margin and in subventricular zone, so those areas of residual disease in glioblastoma patients. And what I've shown you is also that by doing profiling based on single cell, single nucleus, RNA-seq, we found that in the margin, the majority of non-tumor cells are monocytes-derived macrophages. However, we couldn't find specific marker of the M1 and M2 in this area. And so we went on and analyzed this data using Max Spectrum. And what we found is that there is heterogeneity of the population in the infiltrative margin to a higher extent in comparison to the heterogeneity of the macrophages in the tumor mass. And lastly, I hope I've showed you also that the pathway analysis is consistent with those findings, and in fact suggests that also there are distinct biological processes that plays a role in these macrophages. And so these also highlight functional heterogeneity. And I was mentioning about macrophages that rely on antigen processing and presentation, and others that instead express gene associated to oxidative phosphorylation. So with that, I just want to acknowledge all the group. This work that I've showed you is the work of a postdoc in my lab. Her name is Jamilat Dikon-Munot. She's very talented, and she's doing most of all this work. And also it was part of a project of an alumnus of the group, Vanessa Avalos. Of course, we are grateful to all the patient and their family for the donation of all these glioblastoma sample. And we have several collaborators here at the University of New Mexico Science Center that allow us to do all this work that spans from neurosurgery to genomics and bioinformatic analysis. And I also want to mention our great collaboration with UMMC, and in particular with Dr. Chohan and Dr. Perkins. And I conclude by mentioning all our funding, and later on I'm happy to take any question. Thank you.
Thank you so much, Dr. Sara, for such a brilliant talk, and congratulations to you and your team for such a brilliant work. This project was excellent. We won't be able to take the question right now. As Dr. Juma mentioned, we will take the questions for this presentation at the end of the session. For this, let's move on to the next presenter. Our next presenter is Dr. Abid Salim. He's currently working as consultant neurosurgeon, head of the department, Dow Gamma Knife Radiosurgery, Dow University of Health Sciences. And for coming 20 minutes, Dr. Salim will be talking about, he will talk about the role of stereotactic radiosurgery in the current management of craniopharyngioma. So Dr. Abid.
Good morning, everyone. Thank you, organizing committee, for giving me this opportunity to present my work at this venue. I'm going to talk about the role of stereotactic radiosurgery in the current management of craniopharyngioma. So the Cushing described it as a kaleidoscopic tumor, solid and cystic. The word kaleidoscopic beautifully describes this tumor, not only because of the shape and sizes in which it occurs, but also if you see it neuroendoscopically. I will never forget my first opportunity to see it under a neuroendoscope, and what we were startled with when we punctured the cyst. What we could see is a dazzling show of a very sparkling material. In local language, जो हमारे बच्चे अफशान जिस तरह इस्तेमाल करते हैं ना, उस तरह की जो आप you will see the material coming out of the cyst. And it is the most baffling problem to the neurosurgeon, as Cushing described. They are histologically benign neuroepithelial tumors that arise from hypophyseal duct or Rathke's pouch. 1 to 4% of adult brain tumors, but 5 to 10% of pediatric brain tumors. It is the most common non-clad tumor of childhood. It may be solid and or cystic, but most commonly it is mixed with 2 distinct histopathological variants, adamantinomatous and papillary. In adamantinomatous, it characterized by beta-catenin gene mutations and has bimodal age distribution occurring both in children and adults, while papillary is in 95% of cases, it's seen only in adults, and it has characterized by the BRAF V600E mutations. This is the imaging and histopathological slides of the adamantinomatous craniopharyngioma. And you can see the palisaded columnar epithelium, while the papillary one shows the well-differentiated squamous epithelium. And you can see the side-by-side, the complex epithelial architecture of adamantinoma and the not so complex architecture of squamous papillary adamantinoma of craniopharyngioma. A clinical feature at any age they present with headache, visual loss, or hyperthyroidism. And in children, growth and sexual retardation, obesity, and hydrocephalus are frequently observed. Many patients with craniopharyngioma suffer from chronic obesity, which is thought to develop secondary to hypothalamic dysfunction. Memory loss, cognitive deficits are more common findings in older patients. Diabetes insipidus is seen in presentation in 6 to 38% of new cases. Historically, the fact that craniopharyngiomas are histologically benign made them an ideal target for curative radical surgical resection, and which is one key goal was the preservation of VN, and this was particularly so at the beginning of the microsurgical era. The subsequent recognition of appropriate surgical approaches with additional use of different technologies like ultrasonic aspirator, image-guided technologies, and neuroendoscopy. The surgeon's ability to attain radical resection such that craniopharyngioma surgery reached a peak of enthusiasm during the 90s, and leading surgeons presented a large surgical series showing their surgical success in resecting craniopharyngiomas. But following this enthusiasm for gross total resection, the associated mortality, which is up to 50% at 10 years, and the high rate of recurrence despite surgical clearance, up to 50% in some series, became apparent. The endocrine dysfunction was reported in up to 75% of affected children at presentation, with the most frequent being growth hormone deficiency. Diabetes insipidus was less frequent at diagnosis, but its prevalence dramatically increased post-operatively. The preoperative injury to the hypothalamus, incompatible with normal life due to hyperphagia, obesity, behavioral memory disorders, and altered neuropsychological profile, was also recognized. Especially the hypothalamic opacity was reported in 58% of patients with craniopharyngioma at diagnosis, but its prevalence increased dramatically up to 81% following the surgery. The OLA showed that this opacity was related to perioperative hypothalamic injury when radical surgery had been attempted. At this stage, I would like to introduce the Pediatric classification because it will let you understand why, in which cases you will see these complications most commonly. They divide the craniopharyngioma in 3 grades. In the first one, you can see that the floor of the third ventricle has been pushed up. Here you can see the diaphragm has been opened up in grade 0, and here you cannot even identify the hypothalamus separately. So you can see all these grades have been treated surgically, and in grade 2, you can see, although the tumor has been excised, but there is a very severe damage to the hypothalamus. These are the cases which will result in hypothalamic obesity, even if the child survives. So this was a very big study in craniopharyngium 2000 from Germany and Vienna, and which conclude that radical surgical strategies leading to posterior thalamic lesions are not recommended due to potential to exacerbate hypothalamic obesity and impaired quality of life. Treatment should be confined to experienced multidisciplinary teams. And just last month in August in Journal of Neuro-Oncology, this is a paper from the Hospital for Sick Children, Toronto, with James Drake and James Brodka, showing the preservation of endocrine function after Ommaya reservoir insertion in children with cystic craniopharyngioma. So you can see where the pendulum has been shifted. Not only the morbidities, but also the reason for recurrence after resection. In addition to increased morbidity associated with tumor resection, tumor recurrence and the need for reoperation may arise despite initial gross total resection. The Prasad et al. Reviewed results of surgical treatment for craniopharyngioma published between 1966 and 1994, reported that only 35.5% of these surgical series for craniopharyngioma achieved a radical resection of more than 50%, and that even when radical resection was accomplished, tumor recurred in 10 to 50% of the cases. So in order to avoid the perioperative hypothalamic damage, some surgeons prefer to perform a subtotal resection or limited surgery. And now, because partial surgery alone will nearly invariably results in tumor recurrence, adjuvant postoperative irradiation is employed to maximize the tumor control. And the overall survival rates among patients treated by these 2 treatment methods have been comparable. And despite the fact that aggressive surgery is often considered the primary treatment for craniopharyngioma, there is a long history of applying radiotherapy in the treatment of these tumors. So as early as in the first half of 20th century, radiotherapy was considered useful in the treatment of craniopharyngioma. It has been utilized as a primary treatment following cyst aspiration, following biopsy, or after subtotal resection, and as salvage procedure in the setting of recurrent disease. Kramer et al. Was the first to publish a report on limited surgery and radiation therapy for pediatric craniopharyngioma. That was in 1961. And then they published their follow-up data in 1993 with the expanded cohort of 77 children which treated planned limited surgery and radiation. The 10-year progression-free survival rate was 80%, and overall survival was 77%. These results were comparable to major surgical series at that time. So subtotal resection alone results in progression rates of 55 to 85% SS in different retrospective series. The progression often occurs early in this setting within months to a few years after subtotal resection. So the addition of postoperative radiotherapy in the setting of gross radial disease can decrease that recurrence rate to 15 to 20%. The radiotherapy has also been shown to be efficacious in the setting of recurrent disease. The relatively modern series show effective salvage of patients with recurrent disease, and its application that the use of radiotherapy at the time of recurrence or progressing level yields local control results similar to those achieved when the radiation is used in the early period, postoperative period. Furthermore, the overall survival remains high in the salvaged groups. In current literature, several studies have reported safe, effective long-term results with the application of SRS using the gamma knife for the treatment of craniopharyngioma. What we are using in gamma knife is the latest machine named Icon. And it has the very new advantages like the availability of cone beam CT, the latest collimeter system, the possibility of doing either framed or mass treatment. Because of the availability of high definition motion management, we can use the mask as a fixation device. And this high motion management system gives you the ability to stop the treatment at any time if you feel that the target has moved out of your reach. And it has the ability to very precisely deliver the radiation dose because of the dynamic shaping available in this software. And if you're doing the frame procedure, it is a single day procedure. We can do imaging, the frame application, the planning and treatment all in the same day, and patient goes home in the evening. So various series have described the work of gamma knife surgery in craniopharyngioma. The Kobayashi et al. In Japan published the largest treatment outcome series involving 98 cases at a mean margin dose of 11.5 gray and a mean tumor dose of 3.5 cubic centimeter. These others were a tumor control rate of 79%. 0.6%, with a complete response in 19.4% and a partial response in 67.4% of the cases. Other series like Yomo and colleague, well, with a good outcome. Another series by Chung et al., tumor control achieved in 87% of the 31 patients in the study, and 84% is demonstrated fair to excellent clinical outcomes. Then there was the meta-analysis by Minichi et al., and taken together, the published studies on gamma knife therapy for craniopharyngioma demonstrate an average control rate of 90% for solid tumors, 88% for cystic tumors, and 60% for the mixed tumors. So there are various published series on gamma knife treatment for craniopharyngioma. This first one was from our center in 2013. It was published in Dicta Neurochirurgical Supplement, and since then has more than 25 citations. A few cases from this series I would like to show you. This was a male 32-year-old with history of headache and diminished vein. Frontal craniotomy was done, and this was the residual craniopharyngioma, which we targeted with 12 grade 50% isodose line. And this is the result after 1 year. You can see a good resolution of the cystic craniopharyngioma residual. This was the follow-up study at 2 years. You can still see the good resolution. Another child, 33-month-old with headache, vomiting. It was a cystic large craniopharyngioma, which was initially fenestrated by neuroendoscope. And then the residual was treated with the margin dose of 20.5 gray at 50% isodose line. And you can see the 3-month and 1 year follow-up with a good resolution. This is the sagittal view of the same patient at 1 year. Another case, a 7-year-old child with headache, vomiting, a large cystic craniopharyngioma, initially done the aspiration and then treated with the gamma knife. And you can see after 1 year post-op, you can see just the speck of the residual enhancement there. The calcified craniopharyngioma, it was treated with the gamma knife, and you can see that after post gamma knife, there is even reduction in the calcified portions. So there were 35 patients with craniopharyngioma were treated in 2008 to 2015. The age of the patient ranged from 2 to 53. 26 males, 9 females. There were 17 children in that. And this is the age distribution. The mean size was 12 cc's. The prescription dose ranged from 8 to 14. 11 patients had subtotal dissection before gamma knife. 2 patients had neuroendoscopic fenestration of large cystic component. 17 patients had associated hydrocephalus and had VP shunt placed. There were 5 patients who needed Omaha reservoir replacement. 2 patients had previous conventional radiotherapy. The mean follow-up period was 32 months. The patient outcome was excellent in 10 cases, good in 18, fair in 4, and poor in 3 cases. The tumor control rate was 80%, and progression rate 20%. No patients with normal pituitary function, 12 hypoparathyroidism after radiosurgery. Complete surgical coverage was significant favorable factor. So we can conclude that significant tumor control can be achieved with radiosurgery systematically combined with limited tumor resection, cis drainage by neuroendoscopy and or reservoir replacement. The treatment-related neurological deficits are rare. Thank you very much.
Thank you, Dr. Abid, for such a wonderful talk and such a detailed review of treatment option for the craniopharyngioma, which were available in past and future. Thank you so much. We'll take the question at the end for you. Thank you. And with this, now we are moving towards next speaker. The next speaker for coming 20 minutes will be Dr. Michael Geron. And he has an excellent introduction in terms of he's assistant professor and he's been with us for the last 2 days and you'll be seeing him in the next sessions as well. He is a surgical director of Pediatric Neuro-Oncology and Pediatric Neurovascular program at the Monroe Carroll Junior Children's Hospital, Vanderbilt, and the Vanderbilt University Medical Center. He has a great number of excellent paper on his name, and he'll be talking about imagining a perfect world of pediatric neuro-oncology. So Dr. Michael Geron, bear with us, just explore this perfect world.
Thank you. No, it's Dr. Thompson's. That one, yeah. We decided we were going to start timers because I'm so afraid of getting in trouble. Thank you for the kind introduction. And thank you again to the organizers, Dr. Anam, Dr. Shamim, Dr. Mushtaq, all the other wonderful faculty that I've had the privilege to meet, and of course the residents and the students here. I've never given a talk like this before. I've been fortunate to be a part of many great research teams, and a lot of what we focused on is the burden of neurosurgical disease and the absence of neurosurgeons or oncologists and whatnot to address a given disease. And I find that those talks often carry with them weight and a negative connotation because we have such a high mountain to climb and the burdens are so great. But I don't want this to be one of those. And the motivation for this talk, Imagining a Perfect World for Pediatric Neuro-Oncology, the motivation for that, I think you can look no further than this picture here and being here and seeing the young faces, the residents and the students, and the optimism and hope that represents. And so when we talk about imagining a perfect world, of course, for pediatric neuro-oncology, that would mean no child dies of pediatric brain cancer. And certainly I don't have the answer to how to get there, but I do want to spend some time talking about things that we can be optimistic about and reasons I think that we can view a silver lining. So I will touch briefly just to set the stage about our current imperfect world in which we live, some of the ideal benchmarks, and but I want to spend most of the time on reasons that we have to smile and to be optimistic, and much of that is demonstrated by the people that are sitting in this room today. So it is the case that 80% of children with cancer live in LMIC. That's a product of a number of things. One, there's a much greater population in LMIC, but also the proportion of children in many of those populations, the proportion that are children are much greater than many high-income countries. This is pretty profound here. So the global 5-year survival rate for childhood cancer overall is that number there you see on the bottom right, 37%. In North America, that number is 83%. 83% of children survive at 5 years, versus the opposite end of the spectrum in parts of East Africa, 8%. Just think about that for a second. So looking at it a different way, if 80% of children with cancer live in LMIC, in some LMIC, 92% of children with cancer die. That's a crazy statistic if you think about that disparity. I promise it won't be all negative though. I just want to throw these figures out here though. When we talk about understanding what we know about CNS tumors, it's like what we tell our particular junior residents: you don't know what you don't know, and that is true of our knowledge of CNS tumors in much of the world, and that's largely because there aren't great population-based registries in many parts of the world. That is changing though, with the help of a lot of people, including some people in this room. But when we look at what we do know, or what the published data says that we know about these figures, those figures come from a biased perspective. This is probably the most up-to-date figure here, looking at the global incidence of malignant brain and spinal tumors. And all the data that's gathered here, that's in the bottom left, that you can't read, it doesn't matter that you can't read this, because the data is really bogus. Because if you look at the map on the right, where that data comes from or where it doesn't come from is illustrated by all those countries that are listed there in white. That's what we don't understand the disease burden in those places, and I don't need to point out where we are sitting right now, but you see that present there. And this will be the last negative slide I'll point out here, I promise. What this study demonstrates is the burden of brain and CNS cancer, looking at metrics like incidence and deaths and DALYs, which are disability adjusted life years. On the left side, you see there listed low SDI or socio-demographic index down to high SDI countries. And when we look at the percentage of change of the incidence of tumors, you see globally that figure there is 17. That's a positive number. That means that the incidence of tumors is growing over time, and not good, but also that also demonstrates that our population is aging. People are getting older and living longer. But when we look at the percentage of death change, it's dropping in high-income countries where we know that people are living longer, and it's getting worse and worse in low SDI countries. So that gap that's already very, very wide is just getting wider and wider. When we look at DALYs, which is a measure not just of death, but also of quality of life, disability adjusted life years, we see something very similar there too, where we're going in the wrong direction in low SDI countries, while richer countries are seeing improvement. No surprises there, but it is relevant. In the interest of time, and because I promised no more negative slides, I'm going to skip this one for a moment. But I want to talk about reasons again that we should have a smile on our face, and reasons that there are to be hopeful. The WHA, the World Health Assembly resolution in 2017 proposed to reduce the childhood cancer death by 50% by the year 2030. A huge task, given what I just told you about where we currently sit. So that's a huge mountain to climb. A tremendous work will have to be done to get there. But like any journey of 1,000 miles, it begins with one step, and we do have reasons to look at the glass as being half full. When we look at the brain tumor, taking care of patients with brain tumors, that's a big ecosystem, right? It's not just having a scalpel and taking out a tumor, right? So we need to diagnose these in the first place. We need the Noreen Mushtaqs of the world. We need to clone her. We need a lot more neurosurgeons that are not just neurosurgeons, but neurosurgeons that are expert in managing patients with brain and spinal tumors. Of course, we can't operate without anesthesiologists. And if you take something out nowadays, it's not just okay to know what the histologic diagnosis is. We need to understand the molecular underpinnings. Patients need access to radiotherapy, and not just radiotherapy, but affordable radiotherapy, access to chemotherapy, to rehab services and palliative services. And in many parts of the world, efforts need to be made, whether that's radio campaigns or television campaigns, to destigmatize what it means to have a brain tumor, so that parents and husbands and wives and daughters and sons aren't afraid to bring their family members to a hospital. So let's look at each of those, and again, as our benchmark of a perfect world is every child would never die from cancer. How, what is being done right now to try to inch us a little bit closer to that point? Looking at early diagnosis, some really cool work is being done and has been done for over a decade. This is a picture of a neurosurgeon scientist named Steve Schiff, who's been working on developing a low-cost MRI. And just about a year ago, this MRI was unveiled at a hospital in Eastern Uganda, where you can get an MRI for a matter of dollars. And that is just unheard of. And so with this type of innovation, you can imagine how taking this technology and replicating it, eventually this will grow and expand. Look no further than this place here, where we're talking about mobile MRIs that were just completely unthinkable 10 years ago, perhaps even 5 years ago. This is a homegrown system, from a reason that the people in this room, I think, should be really proud and really excited. We need access to safe and timely neurosurgery. I had the great pleasure of working with some awesome teams. This is one of them. And in this effort, we found that there's more than 5 million cases, neurosurgical cases, urgent neurosurgical cases that need to be done every year that aren't being done for one reason or another. And in order to address those, just looking on the neurosurgery side and the capacity building effort that would be needed there, we would need more than 23,000 new de novo neurosurgeons just to address that unmet burden. And this is old. This is 4 years ago. So that figure has probably changed. But in that short duration, there's been a lot of growth. Some of these entities have been present for quite some time, right? The WFNS has been around for a long time. More than 60 or so years, as has FEANS, the Foundation for International Education in Neurological Surgery. But the amount of work that has been dedicated to capacity building and education in neurosurgery, I would argue, over the last 5 years is 10 times what it was in the years before that. The number of WFNS sponsored courses that are ongoing, it seems like there's one every other week in some part of the world. Those are really great courses that young neurosurgeons or residents can be involved with. FEANS has scholarships to train neurosurgeons, both in LMIC and HIC. I'm very proud of the ISPN and the work that some of us are doing in that phase and in that sphere to train pediatric neurosurgeons, particularly in LMIC. A lot of really cool workshops and initiatives that are going on. I mentioned here the Guide to Pediatric Neurosurgery, which is a really neat initiative. I'm proud to be a part of something called NeuroKids, where we're trying to train more neurosurgeons, pediatric neurosurgeons, and by the beginning of next year, we will have training set up in more than a dozen countries. And then, but really, the backbone of neurosurgical capacity building are places like this, flagship places in huge countries that are producing not just neurosurgeons, but world-class neurosurgeons. And I think that's a reason. I know I speak for Dr. Thompson on this. I mean, we're just floored by what's going on at places like this. The globe is shrinking. A number of other speakers have been talking about this. Intersurgeon is a platform that was developed to try to bring neurosurgeons together to enhance training, to enhance the sharing of ideas, where a student can teach a senior neurosurgeon and vice versa, not just how to take out a brain tumor, but how to organize a spreadsheet, how to build a research infrastructure. How to the process of teaching medical students and teaching residents, as opposed to just operating alongside. So those are reasons to smile. There's a lot going on in the realm of oncology and neuro-oncology capacity building. This was a survey that was just I got an email about this maybe a week ago. This is hot off the press here. So just looking at one entity, the NCI, the National Cancer Institute, surveyed NCI centers across the United States, of which there are 67. This is remarkable. 91% of them, usually without any financial benefit or what have you, 91% of them have global oncology involvement. Over half of them offer training in global oncology, not necessarily neuro-oncology, but global oncology. That's impressive across all the countries that you see here. There's a lot of good examples of twinning, this process of twinning, where institutions come together and share ideas and share skill sets that they have to kind of in a manner of of a tide rising all ships, rising the care that's delivered. In my of course biased judgment, none is more illustrative of what can be done and what should be done than what's going on here between here and Sick Kids, Noreen, and what Eric have put together. I think it's really a model for the world. Not that we are in that same conversation, but I'm proud of what's being done at Vanderbilt in neuro-oncology and the partners that we've developed in parts of sub-Saharan Africa, where we're trying to help them understand their burden of disease, build up their capacity. And those are fun relationships to be building. I can't talk about something like this in pediatric neuro-oncology without mentioning St. Jude. And this is a slide I stole from Dr. Boop, but I think what they're doing is a great model for neurosurgery, for neuro-oncology specifically. And then there's meetings like this that are happening, that's happening right now, September 11th, 2022, but it's happening, probably today at another, other parts of the world. These are meetings that bring together the great minds of the neurosciences. And just looking at the committee members here, this is truly a world-class meeting. Definitely a reason for us to be optimistic and hopeful about the future. Just to finish on the neuro-oncology effort and capacity building, I've been really fortunate to be involved in the ARIA guidelines and specifically the low-grade glioma guidelines that we're putting together to try to make sense of, not just the cutting edge of neuroscience and neuro-oncology, but making it applicable to whichever environment you might find yourself in caring for patients with brain tumors, whether that's in rural northern India or in Nashville, Tennessee. You can't do this without awareness and building up awareness. A lot of that impact happens at a Ministry of Health level, but it starts with the science. And if you just PubMed global and neuro-oncology, you can see just how much more attention there is nowadays relative to just a decade ago. It is almost a new field in and of itself. That's a reason we should be excited. And then, even to the lay public, whether you're talking about the Al Jazeera's or the CNNs or the BBC's, more and more of the populace is becoming aware of brain cancer. And I think that's what will help change the minds of the policymakers and the politicians. And I'll finish with an idea that I want to share with you about better and targeted therapy. And this is not in itself a novel idea, but I think it's one that is relevant for this community here and a lot of other communities around the world. But let me just spend 30 seconds describing this notion that pediatric cancers and pediatric CNS tumors are rare, right? They're not as common as a lot of other types of cancers. Investigational therapies require study subjects. We can all agree to that. And there are many drugs out there. There's loads more than what we can use on live patients, but they need to be studied before we can safely use them. And it is the case that if not the limiting reagent to getting these targeted therapies to patients is enrolling sufficient patients to understand whether that drug is safe or whether it's efficacious. And in the United States, you have to pool patients from 30, 40, 50 centers. And even then you might struggle to find the number of patients to get the power needed to understand the science behind the agents that might be administered. In many LMIC, not in all, but in many LMIC, a unique advantage is that pediatric cancer centers are very much centralized, where a single center might have a catchment area. I can speak to, say, a place like Uganda in Kampala, 20 to 40 million individuals in a single catchment area for a single hospital. And so you can imagine how with the right tools, instead of looking at 50 centers, you're looking at 2, 3, 4 centers in a particular part of the world to capture the number of patients needed. And so, of course, there has to be a buildup of diagnostic infrastructure to get there. We have to organize the referral pattern in a better and more efficient way and continue to consolidate the pediatric specialized care. But if and when that happens, it's not a matter of whether these LMIC centers could be leading centers for clinical trials, but they should, because no matter how much money a Bill Gates or a Mark Zuckerberg or Jeff Bezos could throw at studying childhood cancer, you can't pay for more patients with brain tumors, and nor would you ever want to. But that is a unique advantage that is present in many parts of the world. And I think at that point, you wouldn't be in a situation where Noreen would be begging Novartis for a BRAF inhibitor, but you would have the Johnson & Johnsons knocking at the door, begging to be a part of those types of studies and begging to be a part of these teams here. So with that, of course we have a long way to go, but progress is being made. And I think you need to look no further than the bright minds, the bright minds here, the young people here. This should give us a lot of hope, and it certainly gives me a lot of hope. So thank you for your time.
Shukriya, and thank you, Michael, for such a brilliant talk. And special thanks to you for mentioning our surgeons, our oncologists, and their great contribution for making this oncology world for this pediatric patient the perfect, and how they are actively contributing, especially in our part of the world where there are many challenges. Thank you very much. So with this, we'll move on to the next talk. Our next speaker is Dr. Reed Thompson. So Dr. Thompson is the William F. Meacham Professor of Neurological Surgery, Chairman of Department of Neurological Surgery, and Director of Neurosurgical Oncology at Vanderbilt Michael Center. He also holds a secondary appointment as a professor of otolaryngology at Vanderbilt Medical Center. He serves on the joint section of cerebrovascular surgery for the American Association of Neurological Surgeons and the Congress of Neurological Surgeons. Dr. Reed will be talking about low-grade astrocytoma, surgical nuances, and decision-making. Dr. Reed.
Great, thank you so much. Appreciate it. I want to thank the organizers for inviting me, and I'm not sure I want to thank them for inviting me to speak after that fabulous talk by my former resident and now partner, Dr. Michael Dewan. I mean, that was spectacular, and I know that you really poured your heart and soul into that, and I think it's going to inform future discussions, I think, in the next session and hopefully beyond, Michael. So thank you for doing that. I want to sort of shift gears a little bit. I mean, that was such a profound talk, but I thought it would be good to talk about a topic that I'm very interested in, and that is the management of low-grade astrocytomas. I wanted to gear this also, especially for the students and the residents. I'm also going to start my timer because here we go. No disclosures, but I do have something to disclose, and that is that I had the most fantastic run this morning with my new friend, Salman Kirmani, just as the sun was rising, and thanks to the team for facilitating that. It was hot, but it was spectacular and energizing. So a great morning in your great city. Just a prelude, I want to tell you a little bit about where we're from. We live in Nashville, Tennessee, which is in the South. It's a proud city with a great tradition of music, not just country music, but all types of music. And any given night, you can find live music in Nashville, and it's a wonderfully warm place. Would love to welcome you to come visit. Vanderbilt University is a storied university in the South, and the Vanderbilt Medical Center campus is embedded in the university, which is terrific for us as it really facilitates a lot of collaboration with colleagues in Vanderbilt University, particularly in engineering and others. It's a large hospital. It's about a 1,200 bed hospital. We have a large neurosurgery program there. When I came, I was the fourth neurosurgeon, and in 2002, and now we have over 17 neurosurgeons who have grown a lot. But let me talk about low-grade gliomas, again, gearing it toward the residents. And I want to talk about some decision-making concepts of, how aggressive to be, whether to plan a subtotal resection, a supramarginal resection, as some are advocating, a biopsy alone, weaving in key considerations with regard to function as well. I want to talk and spend a minute of time talking about the approach and positioning and how I think that that's key in managing many intrinsic brain tumors, weaving in this concept of brain shift. And there's a lot of talk, as we'll see here in the talk, about integrating data sets like functional imaging and DTI, but all that goes away if the brain is shifted and your image guidance is off. And it's some work that I've done with NIH funding for many years to sort of tackle that problem. I'll talk a little bit about the advantages of the lateral position, why we do a lot of surgery in that position, which I think is helpful. And then I just spend a minute of time talking about some dissection techniques, which I don't think get discussed very often. It's often difficult to teach. And then just a minute talking about some of the future. So I think when you have a patient that, on imaging has what looks to be a low-grade glioma, and this is true, I think, for any of the patients, any of the diseases that we treat, it's really important to establish your goals up front. What is your plan? Do you feel like you should be removing this tumor in an image complete fashion? Are you upfront planning to do a partial resection or a biopsy only? And I think those are important things to discuss and clarify upfront. The imaging modalities for low-grade gliomas largely are the T2 and FLAIR signals, and I'll show you many examples of that. But we are able to weave in other data sets, as we mentioned, tract imaging, functional imaging data sets, which are important. And I think increasingly, we need to rely on our radiology science colleagues to help us understand, and I'll highlight some examples of that coming up. What are the other data that we should be integrating in? What's the metabolic data set that we could be integrating? These tumors are generally not so homogeneous, and I think a deeper understanding of that is going to be important as we understand these tumors better. So, for example, this is a low-grade insular astrocytoma. And, just looking at it, I mean, it's really difficult to image. I mean, there's signal here that looks different from signal here. It's spanning the middle cerebral artery. It's complicated and I think somewhat confusing. This is also a low-grade insular astrocytoma. It's in the insula, but this looks really different, from the previous tumor. And I would like to ask the question, are these tumors the same? And I would argue they're not the same. And I don't think we should be approaching them the same way. And I think we need to start clarifying that there are different populations of these patients. I think this is a very infiltrative tumor without a border. And I worry a lot about function being admixed in there. Whereas this, if you enter that tumor, you can work around the border of the tumor. And I think you can safely resect that tumor with all the adjuncts that we have. But I think these are different. And I don't hear a lot of people talking about that. So I wanted to highlight it and maybe we could discuss it. Gliomas in general, they're challenging to image. They're really hard to see visually, intraoperatively, and we all know this if we've done these types of surgeries because the tumor margins are indistinct. I've been having the same conversation with our chief residents that I had when I was a resident with our attendings. Does that look like tumor to you? I don't know. Maybe just take a little bit more. I mean, that's the state of the art in a lot of ways. I mean, we can map, we can do all sorts of things, but at some level, it's a signal to noise problem for us intraoperatively. I think there are, in addition to the imaging considerations, there's a lot of functional considerations. At first blush, this looks like a frontal tumor. It's not. It's a supplementary motor tumor in a young woman. And, this is someone who I operated on over 15 years ago. And a lot of concern about her function. We'll show some examples of it. But, I think the onus is on us to be very, very mindful that, particularly in these low-grade patients, they have an opportunity to live, if you will, almost to the next therapy. And I tell them that time's on their side in general. So we need to be particularly mindful about preserving function. And this is what this looks like. This is that patient's tumor. And, with some experience, you begin to understand, that just looks different from that. But I think you should use the microscope. I use the microscope on every case for these tumors. I don't think it's old-fashioned. I think it's really important. I think you can see subtle differences as you're attempting to remove these tumors. And that's really important. This is what the post-op T2 image looked like on her in the flare. And she's out 15 years. She now has 3 children, and I hear from her every year, and she's done, really well. But gliomas are also challenging to image, with MRI as well. And, again, sort of the theme here, the imaging, I think, defines our goal. Look at the T2 signal here. It's bright here. It's not so bright here. Look at the deep border here. It seems to respect these white matter planes here. But this is a heterogeneous type of tumor, and so what's the goal here? My sense is that you just need to articulate that goal up front. And I think we need to learn a lot more about what is hidden in the T2 signal, as I'll show you in a minute. So really some of the basic questions that we sometimes don't even stop to ask, what are we imaging? T2 signal does not equal edema. In these cases, that's not edema, that's infiltrating tumor. So what does the T2 and flare signal represent? And I think that at some point you'd like to have a goal that maybe the imaging at some point could replace stereotactic biopsy in establishing a tumor. I think that there are clues to the histology and the biology embedded in the MR sequences. And this is where I think it requires collaboration with our colleagues in radiology. I mean, on the left is a low-grade tumor, on the right is a high-grade tumor, and you just see the T2 signal differences. Monib Ersham, who's a proud graduate of AKU, also a proud graduate of our residency. We trained Monib years ago in neurosurgery, absolutely brilliant. scientist, and I want to acknowledge his contributions here for a minute in this regard. He was very interested in studying invasiveness in glioma, and he was very interested in a marker of invasion called CXCR4. And when he was working in my lab at the time, years ago, established a series of studies that showed that CXCR4 expression mediates glioma cell invasion. We wrote a number of papers about that. Probably has a role in proliferation of glioblastoma progenitor cells, and plays an important role in glioma biology. But this study was sort of lost in all of it, and I think it's a really cool study, because essentially what we sort of asked is, if CXCR4 is a marker of cell and glioma invasion, maybe we should be comparing high and low expressing CXCR4 tumor patients in our tumor bank and looking at their imaging correlates and asking a question: are the CXCR4 high expressing tumors more they have more T2 signal? And that's exactly what we did, and it's exactly what we found. And so what we did was, in this case, it was with a glioblastoma, and we essentially subtracted out the enhancing component of the tumor and the necrotic component of the tumor, and we just looked at the T2 component. And essentially what we found was that the CXCR4 high expressing tumors in this cohort had a much more invasive sort of imaging phenotype than the low CXCR4 expressing tumors, which seem to be more contained. So I love this study, because what it is, it's a molecular marker of invasiveness, CXCR4, that we're correlating with an imaging phenotype of invasiveness. That's cool. And I think, again, there's just tremendous opportunity for us to be not just putting up the images and saying, well, okay, it looks like, low-grade glioma, but there's information embedded in those sequences. So let's talk about a few cases. This is a gratifying case. This is seems like a very straightforward low-grade glioma. There's pre and post-op. We were able to get an image complete resection of that tumor. This is a grade 2 oligodendroglioma in the frontal region. We were able to do also an image complete resection of that tumor. And here's one that had a, let's see, I think I went too far. Subtle finding, but a person with a seizure in sort of this very anterior temporal lobe. I don't know if you can see the subtle T2 signal there, but how do you approach this? I mean, do you come right? Do you do a supramarginal approach and take out, it's a non-dominant temporal lobe? Do you try to preserve the temporal lobe structures? Does it matter? Should we be biopsying it alone? So what are our goals? Well, I don't like going through a normal brain. I don't like taking out radiographically normal appearing brain. And so what we, sort of patting ourselves on the back by this sort of tailored approach, where we went in a terional fashion and sort of this angle and just sort of sculpted it out. And we preserved the radiographically normal temporal lobe. And she actually did well, but I'm mindful that 8 years later, this is not a benign disease. You can still see our nice resection cavity, but this is what this turned into in a glioblastoma. And a lot of work to be done. While we can resect that again, it's moved beyond its biology as a low-grade tumor. Again, function, I think is critical. I really want to pay attention to the work that's coming out, Dr. Dufault and others we've heard from in this conference, talking about mapping strategies that maximize surgical resection safely. But I'm also a little skeptical about the data about these so-called supramarginal approaches. I tend to be very conservative, again, with these patients with regard to their function. I worry a lot about SMA syndrome. In a patient like this, we had one of these cases early on in the seminar. Here's a 19-year-old female with seizures. And again, this sort of subtle abnormality here, just right here in her frontal lobe. Do you watch that? Do you observe it? We felt that she was symptomatic, and we would remove it. So what's our goal? Is an image complete resection of the T2 component of it. But again, it's a little hard to tell. It's sort of merging off in there. Where's the border? This is our post-op imaging, and we were pretty proud of it. We were able to preserve this draining vein and essentially take out the T2 component, and she did well. But here's another one where, again, it's one of these sort of medial frontal lobe tumors that goes almost all the way back. The ACAs are here. And, even though it looks like it's bilateral, it's actually unilateral here on the right side. And this is where I want to sort of weave in this concept of sort of the lateral positioning, because What we've studied in the lab with our engineering colleagues is that if you put a patient completely just supine straight up, there's a maximum amount of shift. The brain sort of slides and you immediately degrade your image guidance. But if you put somebody in a lateral position like this, then what happens is the brain falls away, the falx holds the opposite hemisphere up. You can come in, not having to come through the normal brain, come right inner hemispheric and work to sort of sculpt that tumor out. And there's a lot less shift that's happening in that scenario. So brain shift happens. This is actually that tumor showing you with the tumor side down, frontal lobe. The falx is holding the contralateral frontal lobe up here, and here's the tumor that we're resecting. This is not that case, but it just shows you sort of the park bench set up to do these lateral cases. Several of my residents like to say that my children sleep in the park bench position because it's such a favorite of mine. But I think, trying to understand gravity and how you could use that to minimize retraction and gain exposure, particularly in these cases, I think it's just something to be mindful of. Here's the post-op imaging in that case. Very happy about it. You can see we just sort of sculpted the resection. We're not having to come through the frontal lobe. We're not doing a supramarginal resection. We're removing the abnormality. That's the tumor. Complicated. These tumors are all a little bit different. Here's sort of an opercular lesion. We found this to be pretty challenging. She had a biopsy of this and it came back as a low-grade astrocytoma. And so non-dominant hemisphere, deep here. And when we went in and did a resection on it, it actually turned out to be anaplastic. So even though a non-enhancing tumor, we know that about 18% or less can be higher grade. Here's another low-grade tumor patient, again, with a right arm and leg seizures, very complicated medial temporal lobe tumor. That's a different problem. This is also a different problem. She had, indication that there was intraventricular tumor, as well as this sort of medial occipital tumor. In this case, we just biopsied that alone. I put this one up because this is an example of somebody who came in with tremendous mass effect from this low-grade tumor presenting with headaches. You had this, you could see that the amount of brainstem compression and just this mass that we went in and sort of safely stayed within the confines of his tumor and removed as much of it as we could. But we left this component of this tumor. And thankfully, we kept him neurologically well. He was able to walk. He was not weak. And I was just stunned because 2 years later, all that tumor that we had left, at least radiographically, it really had calmed down after radiation therapy. So even leaving tumor behind and then allowing us a different approach to treat it later, was effective, I think, for him in preserving his quality. In the last minute I just want to quickly talk about dissection technique, because I think it's really hard to teach. It's a tactile feel for these tumors. You need to feel the tumor sort of almost give way to the normal brain. I use biopsy forceps to dissect, to find sort of the so-called edge, use suction as a dissector, find the planes, if you will, with cottonoid patties. The microscope's really important. Frequent checks with image-guided system in the lateral position when it's possible. Just real quick, some adjuncts to imaging. We all are very aware of functional mapping. Our fMRI has gotten so good that we really rarely do awake surgeries now, though we still do it for for speech mapping, but really not for motor anymore. This is an example of that. This is just a correlation between what we see on the T2, what we see here, and then what we see post-op. Broca's region tumor, again, sort of functional MRI. We all are aware of the DTI imaging. Just a nod to some of the work that we've been doing. Again, I think that you've got these incredible adjuncts to imaging like functional data sets and DTI, but if the brain shifts, it really becomes a problem. We've done a lot of work on that. This is actually a laser range scanner that took a map of the actual patient's cortical surface, and we were actually able to then superimpose it on a 3D image, rendering it there. We've done a lot of work in that regard. Finally, let me just say that I'm almost out of time, but I want to mention that one of my passions is trying to develop strategies for us to identify these tumors, intraoperatively. I think if you can see something, you can generally take it out. But we really lack, tumor-specific detection capability. What we need are glioma-specific contrast agents. And while 5-ALA really is a step forward, I think there's a real opportunity for research to develop, markers that will allow us to actually visualize the tumor rather than, some sort of correlate to it. So fluorescent imaging, reflectance spectroscopy. We did a lot of work with some biomedical engineers in the biophotonics group at Vanderbilt, where we've developed a little probe that, light reflecting off a tumor surface is different than light reflecting off the normal brain. And I also think there's an autofluorescence capability that we probably don't even realize we could take advantage of with our microscopes and various filters, because tumors, they just look different, right? But we need to explore it. But the ideal imaging modality would be very tumor specific, and it would actually help us define the infiltrating tumor margins in these low-grade tumors, giving us a real-time interoperative tumor detection sort of strategy. The cool thing, I think, was a series of studies that I did early on. This is some earlier work where we were trying to develop contrast agents that would both fluoresce visually, and also you detect them by MRI. And so this is where an example of sort of working out of your comfort zone with chemists and engineers. We were able to develop a series of molecules, these so-called lanthanide chelates. Turns out gadolinium is a lanthanide, but there are other lanthanides that fluoresce, like europium and terbium. They fluoresce purple, which is my favorite color. So my basic goal is to make the tumor turn purple. But at any rate, this is just sort of what we were able to achieve in a test tube. These fluorescent molecules, this was not a brain tumor model, but it shows you sort of the power of some of the fluorescence. And I think that there's real opportunity on the research front for that. So it's kind of a potpourri, if you will, of low-grade tumors. I just wanted to sort of set the stage that I think that they're complicated. I think there's a lot that we don't fully appreciate on the imaging, the T2 signal, what is it? Pay attention to variability in those tumors. Approach them carefully with regard to functional preservation. And let me just point out, and I used to joke with Monib that we actually do have mountains in the United States. And he says, no, Reed, they're hills. Well, these are some mountains in Colorado, one of my favorite states. And, they may be hills compared to the Karakoram, but regardless. Let me just say in final closing, what a joy this has been. The last few days have been extraordinary experience for me. I can't thank you enough for your welcoming kindness and hospitality. It's been fantastic, and really feel like I've made some lasting friendships here. So thank you very much. Appreciate it.
Thank you so much, Professor Reed, for such a brilliant talk about the surgical nuances and decision-making in low-grade astrocytoma. With this, we are ready to take the question from all of you.
So before we turn to the questions, can I just give you a recap to allow you to formulate your thoughts on that? And I hope Dr. Sarah is still with us. And if you are, can I express my appreciation, because I know what the time difference is, and it's well past. So thank you so much. That's very kind of you.
Absolutely, my pleasure.
And Dr. Sarah, you gave an absolutely fabulous talk on the genetic and phenotypic heterogeneity of GBM, which is really the key, I think, to solving the GBM problem. And your work really shows us that the collaboration between basic scientists, yourself, and the neurosurgeons taking targeted biopsies from the margin, from the subventricular zone, from the areas of necrosis, and working with the basic scientists on this is something that's going to yield a lot of fruit. And I look forward to work from your lab. So Dr. Sarah's talk, of course, invites questions, and I want to move to Abid, and Abid gave a lovely talk on the overview of craniopharyngiomas and his experience and his published series, and has showed us that in an area where mobility has really become unacceptable and to be avoided as much as possible, you obviously have a significant role for stereotactic radiosurgery. Michael, your talk from an author from a developing country in a country like Pakistan on the issues impacting on healthcare as a whole, and of course on pediatric neuro-oncology, was very welcome and an eye-opener. And you're absolutely right. I think that it's one thing for us to focus on the skill level of dealing with the problem, but there's another view of dealing with the landscape of the problem, the global landscape of the problem. So thank you for that talk. And then Reed Thompson, what a lovely experience. You really, I was actually this morning in the student session saying the age of the clinician scientist has gone, because the science has progressed to a level where the clinician can't really keep up and lead it. But you've shown your interest that in not only on the surgical side, but your work towards finding good ways of compensating for brain shift and for good fluorescent tools that would allow us to tackle this difficult problem of sorting out where brain is and where tumor is to be appreciated. So I'm sure that's something that people would want to talk about. We're open to questions, and from the audience, and from things. So please, there's the hand raised there. Yes.
Can I? So, okay. So thank you very much. I just have a comment and one thing on Dr. Thompson's talk. That was an excellent talk. Thank you very much. So you mentioned about the boundaries of the tumors. That's really interesting, because we are going to submit a paper as mentioning, or we are trying to develop this classification where we are grading lower grade gliomas into circumscribed versus infiltrating. And we have like 165 patients in our study where we have seen even, for the circumscribed lower grade gliomas, the length of stay was also less. And the resection that we achieved was better than the infiltrating lower grade gliomas. And some other features as well, for example, like the blood loss and the post-op KPS improvement. I think that was really amazing. So so we have presented this before in SNO last year also. And this year also got paper poster accepted for CNS as well. So that was a really interesting topic when I saw your slide, and so Professor Inam was supervising my work for that. So, have you seen any difference in your clinical practice when you're dealing with circumscribed versus infiltrating tumors?
Well,
in terms of surgical?
I can't wait to see your paper and also your poster at CNS, and thank you for that. I will say, let me say this, that I think one of the challenges is as a surgeon, one develops a sort of an experience over time. You always, you want to say, well, in my experience, because then you sound, I don't know. But what I found challenging is collaborating at times with our neuro-oncologists who, well, it's not challenging to collaborate with our neuro-oncologists, but it's important to help describe to them, who are we going to select for a more radical attempt at resection, and who should we be backing off on? And I think that, for me, when I put up those two tumors, I say they're not the same. I don't think I can operate on that patient on the left and come out of there without giving that person a deficit. I don't think I can and achieve an image complete resection, but I can on the infiltrating tumor side. And so one of the challenges is just, trying to articulate that but I really look forward to your paper codifying it. So.
The lady who had her hand raised.
Hello. Yeah, so I have two questions from Dr. Sara. They will be a bit crude because I'm a second-year medical student. But the first question is that you've shown how heterogeneous the cells within glioblastoma are, right? And we see that the trend is turning more towards targeted therapy, that specific genes or specific pathways are targeted to treat the tumor. So if there is so much heterogeneity, how can we actually apply this targeted therapy concept to these tumors when in an actuality there might be cells that might be resistant to the treatment that is being used? And then I'll ask the second question after your answer.
Yeah, that's, a very important question. The approach has to be, to increase the resolution so that we can have a better sense of which are the genetic alteration and also which of them are druggable. But also to include this approach to look at the dynamics, spatially and temporally, because otherwise we end up with therapies that may not be necessarily effective and we don't know the reason behind that. But also, we need also to move forward in looking more at the influences of the cell population. So we can't just think of targeted therapy in the context of genetic alteration of the tumor cells, but as well as inhibition of mechanism of crosstalk between the non-tumor cells and the tumor cells. So you may know about all the work that has been done by several investigators about inhibiting mechanism of crosstalk between non-tumor cells such as macrophages and tumor cells, but those have been limited to the tumor mass only. But that, just also gives an idea of a certain area that needs to be investigated further in order to then develop additional therapies that may be successful on top of those targeting genetic alteration.
Thank you. And the second question is actually related to this exact point that, you talked about how there was a whole, there were M1 macrophages, right, in the margin of the tumor. So what we've been taught is that this is an arsenal of cells that are capable of killing, So is it possible that we could, use these cells, or just like CAR T therapy, we could induce some change in these cells so that they can attack the tumor specifically?
Yeah, that's the hope. So in the margin, actually, what you see is a lot of heterogeneity, not only M1, but also you need to keep in mind that for glioblastoma, what has been described, and again, this has been described limited on the tumor mass only, is that even the M1 and M2 actually follows a continuum between them. Now, the switching between the two, because of this continuum, is not easy, is not two poles in which you can switch one to the other. But definitely by understanding better all the functional heterogeneity, you can, better elucidate this mechanism and trying to convert those that are more tumor supportive into either inert cells or tumor suppressive.
Thank you.
Hi, so I'm a final year medical student. So my first question is from Dr. Abid Salim. In terms of, you mentioned about the prognosis of craniopharyngiomas using stereotactic surgery. But what was the prognosis in terms of endocrine complications and the outcomes?
Yeah, in that series, I mentioned that we followed with the endocrine functions, and all our patients which already had a normal function continue to have the normal function of the pituitary in the series which I presented.
Thank you. So my second question was from Dr. Devan. Firstly, thank you so much for that really enlightening talk. That was brilliant. But Dr. Devan, what in your opinion, so we have most of the medical graduates from LMICs, like we have the most medical graduates from Brazil, then India, and then Pakistan, and then for the other countries, right? But still, LMICs lack good enough medical training, and they do not have expertise on most of the topics. So you have a lot of medical graduates graduating medical school, but then we're still lacking doctors in the LMICs. What is your opinion on that? Do you think that they should be trained by people in the developed world, or they should have some other resources, like you mentioned, some online resources where you could train other people sitting somewhere else in the world?
Well, thank you for the question. I guess I'll start by saying I'm not sure I totally understand the question. So you're saying that the majority of medical graduates graduate from LMIC medical schools, but that there's insufficient number of physicians. Was that I just want to make sure I understand the premise of your question before I attempt to answer what is likely an unanswerable question. But a great question though, an important question. I'll answer what I think you're asking, and I don't know the answer to that question. I suspect that the part of what you're describing has to do with is a very complex one that has to do with how medical graduates are employed in hospitals and clinics in LMIC and HIC. I think that's a big issue and a big problem. How a Ministry of Health is allocating resources to compensate medical graduates. So I think that part of that answer resides in perhaps what patient population you're talking about and what field and what subspecialty you're talking about. For neurosurgery specifically, I think it depends entirely on kind of where you are and what the hospital needs and what the community needs are. But there's no question about it that there is a tremendous need for more neurosurgeons. But in a world where a government allocates a finite number of funding for a seemingly infinite number of pathologies, it is the case that neurosurgery, which is not the most cost-effective intervention, gets left on the sidelines.
Michael, while you're up, so a lot of your work focuses on unmet need and manpower on the ground. So numbers of practitioners, numbers of neurosurgeons. But in developing countries, a lot of the problem is actually access and financing. And so it'd be interesting to actually look at the problem from that perspective and see whether the large burden and the unmet needs and how they correlate with the outlays that are available for financing and access in terms of geographic access. Because that seems to be the big thing. What are your thoughts on that?
Yes, I think, thanks for the question. You're absolutely right. If I can be honest, what you're seeing there is really what we did is really the easiest way to try to measure a problem. In that the deficit of manpower, the deficit of neurosurgeons is but only one marker of a very large problem, but one objective means to measure the scope of the problem. But you're right. I mean, the limiting factor when it comes to patients getting neurosurgical care goes far beyond just a beating heart that's trained in taking out an epidural hematoma. It's getting to the hospital. It's affording the CT scan and the operative care and the postoperative care and all the things that come with that. I don't know if I can answer that question.
Yeah.
I don't know. And I think that, but I do think it begins with, I think if we are not going to see really dramatic strides from just the conversations that happened in an auditorium like this. I think those changes have to happen at a much higher level by individuals like elected officials. And it's getting those ears to care about these problems. I think until that happens, the steps that we make, albeit positive, they will be somewhat smaller steps.
Plus, I think trying to draw the attention of the bilateral, multilateral, international donors who are interested in pediatric issues, but away from the standard pediatric issues to neuro-oncology, pediatric neuro-oncology.
Yeah, well, and to that end, selfishly, as someone, and many of us share this view that care about pediatric neuro-oncology, one thing that we do have going for us is that it is an easy product to sell to anyone from elected officials to wealthy donors. I mean, it is a easier product to sell than I think some other medical conditions, and but it's also, but I think it's okay to sell that product because it is such a complex and neglected product in much of the world, most of the world.
Michael, as they stay in the States, thank you for your service.
Coming from you, that's not lost on me. Thank you.
I have a question from Dr. Michael. So it might be diverging slightly from the topic because it's not related to peds oncology or neurosurgery, but because you are a pediatric neurosurgeon. And one of the slides you showed was also regarding spina bifida, right? The neural tube defects. Now, how much do you think, and of course, neurosurgery is a very important component of managing it. But very recently, an AQ alumnus who also works at Bill and Melinda Gates Foundation, Dr. Anita, was talking about their efforts on the Future Fortified Global Summit on food fortification, on interventions such as folic acid, on actually reducing the burden of these defects in Africa and Asia. How important do you think are interventions even before the disease is actually taking place? Because I do not think personally that we would ever have enough neurosurgeons to treat the burden of these neural tube defects if we do not take the primary healthcare interventions.
Of course, it is hugely important and more important. I mean, right. It's like vaccinations, right? If you can stop the problem before it ever occurs. Because keep in mind, as neurosurgeons, we're not injecting stem cells that actually work and regenerate tissue. All we're doing is closing a defect to mitigate the risk of things like post-infectious hydrocephalus and meningitis and the cognitive decline that can follow. So yeah, of course, but it's also the case that you can walk and chew gum at the same time. There are people that are probably better than some of us at advocating at that level, and many of them are neurosurgeons that some of us know that are doing that work right now and seeing success in that in the way of national folate fortification. So that's hugely important.
Dr. Reed, if I can just ask you, I'm quite a fan, Dr. Thompson, of the lateral position in the way that you do it, contralateral, the side down. But for your purposes, I would be worried about the inability to get lateral when you're thinking. So just tell me what you're thinking or what your experience with that is.
Great question. I think you have to look at the tumor individually, but what I've discovered is that you can get around it. You can get lateral, and as you start to deliver it, there's more room there. So and as there's more brain relaxation over time, as you continue the resection, the corridor opens up even wider. And so I've sort of begun to learn these dissection techniques that allow you to really almost pull it up. But you're right. And so the lateral position also can be not just for intrinsic tumors, like we've been talking about, but also for example, deeper seated, meningiomas or metastasis or what have you. But you're right. Where I've run into the problem in the lateral position actually has been in the central neurocytomas. So you have this huge interventricular tumor, central neurocytoma with a dilated ventricle on one side. And then you put the tumor side down, you come in, And there is the exact scenario where I've encountered what you're asking, which is very difficult to get all the way around it sometimes. But often as the tumor starts to deliver itself, you have a little bit more room, I think. What do you think?
So on one level, yes. The other thing is that as it debulks and as you get CSF flow, it falls away from you even further. And as you were describing, I was just thinking to myself, I wonder whether a 45-degree scope would help at this point. Right?
Yeah, good thought. Yeah, or a mirror. Thank you.
So we're just at 12 o'clock. The last question.
So my question is for Dr. Reed. Thank you, Dr. Reed, for an excellent talk. What is your experience of using Interop ultrasound for such low-grade glial lesions?
Right.
Because rest of the adjuncts are, very expensive, and we do have our limitation for that, especially from LMIC. So what's your experience of this?
Yeah, I think that as Michael was saying earlier in one of his talks, he's become a real advocate of using it. I mean, I think it has a definite role, and we use it not infrequently. I wouldn't say we use it every time, but I do think that it's generally a low cost. One thing you have to really do though is you really need to spend some time, I think, with ultrasonographers to help you understand what it is you're seeing. And I think that the times when I've been thrown off have been when, there's blood in the resection cavity or would have some echogenic material there. And you think you visually had the tumor resected to the degree that you want, but then you use the ultrasound and then you go back in and it's kind of like, oh, what am I looking at? So, but absolutely, yes. And I think that we, as neurosurgeons, really ought to be using it much more frequently. But I think there's a certain lack of sort of comfort with interpreting the images, at least that's what I've discovered. Also, we need to understand how to turn on the machines. It's kind of like, okay, how do you turn that thing on? So, thank you.
Thank you. So once again, thank you to Dr. Sarah for staying with us. And thank you to Dr. Abid for coming across. Michael, Reed, great pleasure having you in Karachi and contributing so much to this conference. There's just one last thing that I want to mention, and that's there's an online question from a gentleman who wants to know about clinical trials and oncology collaborations with an institute in the US in Phoenix, Arizona. And I don't think that information is available at hand right now, but our scientific committee chairman, Dr. Shahzad, is available to you if you can get in touch with him, and he should be able to put you on the right track. So if you want to say thank you.
Yeah. So it's time to wrap up the session. Considering the name of the session, the cutting edge in neuro-oncology. Our esteemed speakers of the session today, they did their job brilliantly to justify the topic of the session by sharing their experiences, their presentation in this challenging field. In addition, I would like to thank the chair session, Dr. Juma, for making to creating the productive discussion and fruitful discussion. It was really, really helpful. And with that, it's time to conclude the session here for our audience. Have a great day and keep hydrating yourself for the next session because it's going to be really hot, sunny day today.